in, and this is being recorded for anyone who's attending here or who's not able to attend. We will be sharing this after. Oh. All right, we've got about 37 folks, so we'll just give it one more minute. All right, well, good afternoon and thank you. Welcome to everyone who's logged in. We appreciate you joining today's webinar on how digital social determinants of health screening and navigation drives action and reduces administrative burden. My name is Stacy Sand. I'm the Vice President of Marketing here at GetWell, and we are really excited to tackle this challenge with you. We know that you are dealing with many needs in the communities that you serve. You're dealing with a lot of things from your regulatory side, changing reimbursement models, all related to SDOH screening and data capture. So I think you're really going to get a lot out of today's discussion with our panelists, who I'll introduce in a moment. First, before we introduce our panelists, I'd like to just share some tips for using the Zoom webinar today and for engaging in this webinar. By default, everyone will be muted once the webinar begins. If you would like to ask a question, you will see a Q&A box option here. So you can click on that, you can enter your question and then click send. And then at the end of the presentation, we will have a moment to answer questions, but you can feel free to enter your questions at any time during the webinar. So I'd like to introduce our speakers today. I'd like to introduce Dr. Arvin Garg, who is a tenured professor of pediatrics and the vice chair of health equity at University of Massachusetts Chan Medical School and UMass Memorial Children's Medical Center. He is also he's also the Associate Chief Quality Officer for Health Equity for the UMass Memorial Health System. In addition to this work, Dr. Garg is also the founding director of the Child Health Equity Center at UMass Chan and UMass Memorial Children's Medical Center. He is also the program director of the Child Health Equity Fellowship. He's been recognized for his clinical teaching and mentorship with awards from medical institutions throughout Boston, and his research focuses on advancing child health equity by addressing adverse social determinants of health, much of what we'll discuss today, within the delivery of pediatric care, particularly for low-income families. Since 2009, Dr. Garg's work has been continuously funded by the NIH, and he has also received funding from private foundations and has published over 100 publications. Dr. Garg is also the president-elect of the American Pediatric Association. Thank you, Dr. Garg, for joining us today. I'd like to also introduce from GetWell, Dr. Chelsea King-Arthur. She is the Vice President of Ambulatory Products and Analytics and Population Health Services here at GetWell. She has over 20 years of experience in healthcare innovation and policy and has worked tirelessly to ensure that underserved patients and their loved ones experience a healthcare system that works for them and empowers them to a healthy life. Chelsea has previously worked at Cigna HealthSpring and United Healthcare on their Medicare Advantage and Medicaid products, as well as having served as the Director of Innovation at Inovalon and leading CMS quality projects at Semantic Bits. Chelsea holds a Doctor of Public Health, as well as a master's degree in Healthcare Administration, and her research focuses on leveraging health plan benefits to address social determinants of health. We are so honored and really thrilled to have both Arvin and Chelsea here today for this important discussion. Today, what we're hoping you come away with are the following strategies related to SDOH data capture. We would like to share with you today ways that you can optimize your data collection, integration, and how you navigate your patients. We would also like to share how you can incorporate AI-enabled tech and human navigators to more effectively connect with your patients and get them to social need resources. We will also cover strategies on how you can streamline your SDOH workflows and reduce administrative overhead. And then Dr. Garg will lead us in a discussion and a conversation with Chelsea on how UMass Memorial Health used GetWell to screen thousands of patients and navigating them, especially at-risk patients, to valuable resources. With that, I'll turn it over to Chelsea, who will kick us off and lead the discussion.
Thank you, Stacy. So I just want to quickly kind of ground us as to why we're here. If you hop to the next slide. We all know that social determinants are a thing that many regulatory bodies have placed a focus on since 2023. And we know that CMS is requiring basically every hospital system who is reimbursed or financed through CMS to ensure that they're screening 100% of their high-risk patients who are over the age of 18 during every hospital stay. And we also know there are other regulatory bodies out there. So NCQA, Joint Commission, various state Medicaid agencies who also have created regulations tied to social determinants. And so we know that everyone is now kind of facing regulatory pressures to ensure that SDOH screening is happening and that we are taking the time to understand the needs of patients. On the next slide, it's not just about screening, though. With that screening, we also know that with all those regulations comes the potential to be penalized. And so we know that for hospitals who fail to meet the program requirements, they can see a 1/4 reduction in their annual payments under the IPS payment system. And so it's really imperative that organizations find the ability to focus on SDOH screening and resource navigation. But if you look at the next slide, what we also know is that we've put a lot of reliance on existing technologies. A lot of organizations have made massive investments in their EHR systems, as you should. It is very much the backbone of what healthcare delivery looks like today. But we also know that those particular systems might not be the ones that are leveraged by under-resourced communities. So we see that portal activation can be fairly low, around 15 or 40%, and that marginally underserved communities, Black and Brown communities, those communities that speak languages other than English, might not engage or have less access to those portals today. And so how do you make sure you're engaging those patients who very well might come from under-resourced communities and thus have greater needs, and make sure that you're reaching out to those populations to get them engaged, asking these really important questions so that you can service those needs and help to overall influence their overall care. On the next slide, just very quickly, we're super excited about the work. Next slide, Stacey. We're super excited about the work that we've been doing here at GetWell tied to SDOH screening and resource navigation. It's not something that's new to us. As an organization that has been focused on health equity for many, many years, we're super excited to have pulled our SDOH screening and resource navigation program out as a standalone program where really our goals are kind of threefold, really easy. We want to optimize the data that's captured, right? We believe that any organization who is out to get this information will be most successful if they can do it in a multimodal approach. We believe that you just can't collect that data, but you have to actually do something with it. So turn that data into action by providing patients resources right at the tips of their fingertips so they can go out and help to kind of address those needs. And then make sure that you're fostering healthy communities, building those relationships with those CBOs, ensuring that the clinical team has the ability to scale, that the social worker teams have the ability to scale, so that we're making sure that overall we're addressing those needs, but doing so while also building our community. And really the value of the program that we have in place, on the next slide, we'll see that it's really about increased engagement. I think we'll hear a little bit from Arvin about that. It's about building that greater community, not just externally, but also internally. I'm really excited for Arvin to kind of talk you all through what the UMass Memorial team has done kind of collectively from an enterprise-wide to really build out what SDOH screening and the importance of it to their organization means, and then really easing the burden for the clinician team. And so it's about making sure that if you're screening everyone, if the ask is for that screening, that you have the ability to take some of that burden from the clinician, from the clinical team. They're not sitting down filling out surveys. They're not making sure that every patient they see has completed it. They're allowing technology to help put that work forward for them so they can focus on the really important task of taking care of their patients and ensuring that the rest of their clinical colleagues are supported in the business of taking care of patients. And so we're really excited about that. And on the next slide, you'll see that really it works, right? So patient love can turn into opportunities that can turn into financial growth. And these are just some of the comments from patients from UMass Memorial Health. We have an internal channel on our internal Slack where we collect comments that come in from patients and we share them with our team as a means of motivating the team, but also showing that the work we do has meaning. And so these are some of the comments from UMass patients. It's really exciting to see the work and to see the impact it's having on patients. And so I'm really excited to jump in, enough talking from me, and to jump in directly and start with Arvin. And so Arvin, if you're willing to join me.
Of course. Thanks, Chelsea.
Yeah, no worries. So I think I'll just give you a little bit of time to kind of talk about the organization. Tell us a little bit about UMass Memorial Health, and then we'll jump into some questions I have prepared for you about your processes and work tied to SDOH screening and resource navigation.
Yeah, absolutely. So just a background, I've been in UMass Memorial Health for about 3 years now, and it's the largest safety net hospital health system in central Massachusetts. It is the second or third largest health system in Massachusetts overall. We have one large tertiary medical center, UMass Memorial Medical Center in Worcester, Massachusetts, which is the second largest city in New England after Boston, the city of champions, after the Celtics' recent Banner 18 trophy. I'm a diehard Boston sports fan, so
I will yield that to you.
Born and raised outside the Boston area. So it's a very mission-oriented health system. You know, the majority of our patients are on public insurance. In our Children's Medical Center, over 60% of our children are on Medicaid. And so it's a very mission-based hospital and health system. So we have the medical center serving Worcester, and we have 3 community health community hospitals in central Massachusetts also serving their communities at large.
Perfect. So a nice sizable urban health center who's out there serving patients who a mixture between underserved, under-resourced, and maybe some who are resourced as well. Makes total sense. So can you tell me what started UMass Memorial down the path to focus on SDOH screening as kind of an organizational priority?
Yeah, absolutely. So I'll start with myself, then I'll pivot to the institution. So for me, this is something I've been doing for about 20 years in my research area. So I was a fellow in Baltimore. I had to I know, Chelsea. I had to move back to Boston because of, I had to raise my kids as Boston sports fans. But besides that, it was an amazing experience. And when I was down there, I had to do a research project. And I was kind of struggling my first few months trying to figure out what would be meaningful for me to conduct. And I was precepting residents in the Harriet Lane Clinic, which serves East Baltimore, and multi-generational families of poverty, living in poverty, related to segregation, racial racism, structural racism. And the residents were doing amazing jobs explaining to me the health conditions of the children that they were serving. They were serving as their pediatricians. But in that context, I was able to take a step back and think about what was really driving these children's health and development. It's really these social factors, these social drivers of health that relate to food, housing, employment, education. Again, related to poverty and related to wealth and related to structural racism. And thinking about, is there a way we can use the medical visit to quickly identify needs that families want help with and try to link them to resources? Because if we can do that, we could potentially positively alter the trajectory for our children that we're taking care of. So that's kind of been my side project for a while. I've been doing it in Boston. I was in Boston before coming to UMass and doing that type of work for a while. And there was a staff member at UMass Memorial Health, her name was Chris Cernak, who did this as a passion project about 6-7 years ago. We were doing work at Boston Medical Center. She had heard about this work and she wanted, knowing the mission of our institution, knowing the patients that we serve, she really wanted to get this up and running. And she single-handedly did this in many, many practices at UMass Memorial Health. And then I came along about 3 years ago and we weren't doing any screening in our pediatric primary care clinic. and we're able to do something very similar in our clinic. And that's kind of what was going on until these regulations came down the pike, about a year or two ago.
Yeah. So you guys were already focused on it, and the regs just kind of helped propel you forward a little bit.
It accelerated quite significantly. So it became beyond just passion projects from Chris and from me to really being an institutional priority, given the ramifications if we didn't complete this. And so the other thing that happened also was within the past year, we joined an ACO. We became an account care organization. So Mass Health, which is our Medicaid program in Massachusetts, turned into an ACO many years ago, and UMass Memorial Health joined just recently, about a year ago or so. And as one of the quality metrics on the outpatient side for our Medicaid patients is to screen for social determinants of health. And so between that regulation and CMS coming down the pike, and then there's also regulations from Mass Health. We like to be a little bit like outliers in Massachusetts and try to like be ahead of the curve. And so as part of the acute payment system for hospitals, acute hospitals, to try to help redistribute some of the funding to more safety net hospitals, that was also a benchmark to implement SDOH screening across the system, both inpatient and outpatient. So we had 3 different regulations that make sense. So one was for the ACO for our Medicaid patients, one was for CMS for all adult hospitalizations, and then one was from Medicaid from the acute hospital payment system, which is about $25 million worth of risk, and this is part of it, that wants us to be screening inpatient and outpatient, and ultimately in the ED as well. But that's it's in, then it's out, it's in, it's out. So, but that'll be coming down the pike in the near future as well. So from 3 levels of regulations, there was actually a cost impact if we didn't do this correctly. We did this at all, and then if we didn't do it correctly, it could have unintended consequences, could have negative consequences for our patients and families that we serve.
Yeah, that makes sense. So you have these major 3 regulatory pushes for you, and then the penalties or the losses that could occur if you were doing it right, or incentives that are there. And so you have outpatient, you have inpatient, you have ER coming. With those 3 settings, how did you all determine like which methodology would really garner the most success? How did you kind of coalesce around a plan to push UMass Memorial Health forward with SDOH screening?
Yeah, it's a great question. I have to say I'm very grateful that I had the year of leadership for us to be thinking about this. I work under a really transformative leader, Dr. Arvin Garg, who's our Chief Quality Officer, and he's had this partnership with Get Well for many years, and he's just an innovator and really thoughtful, and that's the type of institution we are. We're very mission based, and so we didn't want to just check the box. We wanted to do something meaningful for our patients. But we also had to realize what resources we had currently, and post-COVID, every health system is struggling with financial difficulties and challenges. And so what do we do in a resource-limited environment to do the best we can for our patients and families, knowing that these regulations are here, and we want to go beyond just checking the box. We want to, if we're going to do this, we want to do something meaningful. And as I mentioned before, I've been doing this type of research for the past 20 years, had some successes, but a lot of failures in the work we've been doing, particularly in trying to translate the work we found with positive results under very controlled conditions and translating into real world conditions. And so that kind of helped inform me some of the challenges we would have when we kind of scan our environments, for this large health system, which serves, I think, over 250,000 adult patients, almost 50,000 children. We had one navigator across the whole system. We had some social workers in some clinics, but other clinics didn't have any social workers. We have a busy workforce, and adding one more thing to our already burned out workforce, which again is very similar to any health system across the country coming out of COVID, just seemed like a lot to do. Yeah. And then we looked at some of the data that we have and some of the research findings that we found, showing that, for example, that when we did some studies in community health centers in Boston, and we found that the screening rates weren't all that great. That patients, and our screener says basically, do you want help? So any patient says they want help, we need to do something about this. And we found that there were some racial and language disparities, inequities in getting those resource sheets and referrals. And, that was something that was kind of troublesome. And then anecdotally in clinic, and this is something I eat and breathe all the time, but when I'm busy in clinic, there are patients that had filled out a screener in our clinic, again, my passion project, that I would often forget to give a resource sheet or actually acknowledge their answers until after they left. And so I think all of that kind of made us think about, okay, what can we do that in the name of health equity, this is what every health system, every regulation that's coming in pike is saying, we're doing this to advance health equity. And I think conceptually that makes a lot of sense. We're trying to move more upstream to really address and mitigate some of the adverse drivers of health that are tied to socioeconomic and racial factors in this country, because those two are locked since inception of our country. But knowing that if these regulations are really well-intentioned, even just based on our research studies, potentially we could be actually exacerbating inequities in the way we're doing this. And we'll show some data that, we're looking at the data, which is really important. So one other thing, I'm gonna let you move on to the next question, is that the work isn't done by just implementing a screening and referral system. The work just starts. You have to be introspective. You have to look at the data, and you have to see where there are differences and see how you mitigate those differences. And if there's racial differences, there's a framework from Dr. Kumar Jones that says that if there's racial differences, it's due to racism at the structural or interpersonal levels. And we have to, we can't continue to be part of the problem in exacerbating racial inequities in this country, particularly with these mandates that are focused on us to try to address health equity. And so we really need to think about where is that seeping into the outcomes that we're seeing, not only the health outcomes, the healthcare utilization outcomes, but also this SDOH screening and referral outcomes that are now being part of the healthcare system and part of the vocabulary and part of our day-to-day work that we're doing as part of the healthcare system, as part of being a physician, nurse, nurse provider.
Yeah. So if the overall purpose of the regulatory shifts, I think we agree with this, are to reduce health equities. But as you said, if you're looking at the data, you have to be introspective. You have to, as I like to say, you have to step to the table eyes wide open, right? Like you have to understand and look at systematically what's going on. How do you recommend, what would you recommend to organizations trying to make that shift, trying to meet the regulatory requirements, but also understand that this is tied to health equity and also understand that there's a role for them to play in it? What is your recommendation to them as they try to make that shift?
Yeah, there's a lot there. How much time do you have left? No, I think we just have to be humble, first of all, that we're not going to get it right the first time. Like no one's going to get this right. And we have to expect that the system that you're going to evolve, that you are going to implement, is going to evolve over time, and it's going to get better. I think we have to think about, are we causing more harm to our most vulnerable patients? I think 3, you have to think about the healthcare system. There are many communities, many patients, many families that we serve who do not trust the healthcare system, and justifiably so, given the historic trauma that we've done to patients of color, particularly Black Americans. And so we have to acknowledge that a patient may have, the 4th thing I'll say is, patients know whether or not they have enough food for their family. They know whether or not they have adequate housing. They know whether or not they have transportation. They know whether or not they have utilities need or not. It is not our place in the healthcare system to make a diagnosis for one of these social needs as a marker of poverty and tell our patients, you are food insecure, you need to get help. That is not what we're here to do.
Yeah.
So what we're here to do is to earn the trust of our patients and families, And if they want additional help, we have to recognize and we have to accept that our patients are working their darndest to try to get out of these circumstances.
Yes.
No one wants to have not enough food for their children.
Yes.
No one wants to live in a crummy house. And so we are here to help support patients and families along their journey to try to secure the appropriate resources to gain the right education, the employment opportunities. That is what we're trying to do. And as the anchor institutions, we need to think about furthering more investments into those disadvantaged communities. And so we have to respect whether or not a patient wants help from us or not. And we are not trying to make a diagnosis of food insecurity. Just like, we should be making a diagnosis of diabetes and hypertension, these silent ailments that patients have no idea that they have. But when it comes to social drivers of health, social determinants of health, health-related social needs, our patients know, and we have to respect whether or not how much they want to engage with us to help them along their journey to ameliorate those needs.
Yeah.
So there's a lot there.
Yeah.
I think a lot of the screening regulations focus on kind of making a validated measurement using these validated measures on identifying food insecurity, housing instability, for example, but that doesn't correlate one-to-one to a patient wanting help from us, from the health system. And we have to recognize that as we move forward. And so as part of our screening system, we do that for the regulations to understand the prevalence rates for these conditions for our patients' families, but then we call a second part of screening, a social needs screening, where we ask patients, do you want help from us with food, housing, employment? And they say yes. We know where that patient stands. We know that they want help, and it's our duty to help them. Unfortunately, we've seen in our research studies, and then me anecdotally, that not every family, because of the workflows are so busy, oftentimes not intentionally, but that many times patients who say they want help in our studies have found that, only about half the time they actually got help. So we wanted to figure out how do we mitigate that as well. And so that's where we started talking to you guys.
Yeah. And so speaking of that, I was telling you through the prep of this, and I promise I'm going to find this email and send it back to you. About a year ago,
spam, right?
It's not spam. About a year ago, we received an email after having some preliminary conversations where you all reached back out and let us know that you thought that the approach we were taking, the collaboration we could have together would help you all meet the goals that you had in place. And yes, I forwarded that email to a colleague and said, is this spam? Is this real? Is this actually Arvin's email address? And it was. So can you tell me what about the solution struck you as kind of the best tool for you all to be successful with your screening and navigation goals?
Yeah, so at the time that we're having these conversations with Get Well, and Dr. Alper had a relationship with you guys, and there's trust there, and some of the presentations that you guys had done, I just felt like a connection, and felt like we're doing it for the right reasons, and we're going to be authentic in these conversations we're having and thinking about what we can do best for our patients and families. Like that was at the center of the work we're going to do, which really excited me. I think at the same time, we're doing this work in the health centers in Boston. And again, because of COVID, because of the murder of George Floyd, we try to be more introspective with our data. And we looked at data in a way that I probably wouldn't have done before. And we found this concept of double loss. So families said they wanted help. About half of them didn't get the help that they wanted. And then there's some racial inequities, and particularly Asian families, Latino families were less likely to get help than our white families were. And that was really troubling to me because I thought, even before we did this work in the scope of health equity, my purpose was try to do good for our patients and families, and seeing those results was just really sobering and really painful, actually, to see that the work we're doing is actually in some ways hurting patients and families. And I stumbled upon this concept of double loss. There's some researchers in New York who use this term in children, in pediatrics, where patients, and they did this with focus groups with low-income families and low-income parents, and parents describe this double loss. So the first loss is that patients and families and parents, in particular, because in pediatrics, are disclosing a need that they have.
Mm-hmm.
No one wants to disclose to a pediatrician that they don't have enough food for their family.
Yep.
So there's shame, there is guilt, there is feelings of being lesser than others.
Yep.
But because of their love for their children, their love for their families, they are willing to disclose this to their pediatrician. And we found that pretty high disclosure rates, again, at the Sapien Hospital in Boston, at BMC, and community health centers, between like 50 to 70% of families had at least one need that they wanted help with. And then the second loss is if they don't get acknowledged. So they're disclosing to their pediatrician that they don't have enough food for their family, and then nothing happens. And that's a double loss. And because of that, it causes pain to patients. They're being brave to share their needs, and it's not being acknowledged. And so it can lead to mistrust for patients and families with the healthcare system. And so, and within that context, we were looking at that and recognizing that that's what we're doing with this work. And we need to think about, how do we ensure that every patient who says they want help with a need gets something, a resource sheet, gets some type of acknowledgement, something that happens within that visit. And just from my own clinical experience, like we've tried to put smart phrases in Epic. We've given out resource sheets and resource books. We've trained medical assistants, we've trained physicians, we've trained front desk staff. Everyone's just so busy, right? And so, you know, I can really use my smartphone. I can really use my iPhone. So I'm not like an AI guy or technological guy, but when I heard that you all could text resource sheets within minutes of patients saying they complete the screener with their needs, and that regardless of race, ethnicity, status, they would automatically get a resource sheet. It just kind of had like an aha moment for me. Like, okay, like we can do all the training we want. Even me, who's like well versed in this, who wants to do this, oftentimes I forget in clinic to give out the resource sheets. This might be a way to really advance health equity and make sure that we mitigate double loss for our patients and families moving forward.
Yeah. So it was creating that assurance that if someone expressed that need, that they were getting something in their hands. And so making sure that we're not kind of creating that double loss. Yeah, it's very important, very well understood. So I'm going to, I want to know kind of, what do you think advantages, disadvantages to how you all are approaching your screening and resource navigation work? Like what's working well, what's not working well? What are some things you could be doing differently, or things that you feel like you all are really excelling at as you do this?
Sure. It's a great question. And I can show you some data in a minute or two. The other thing that I think really got us excited was is that we only had one community health worker and across the whole network, and we had limited social workers in each clinic. And so some clinics didn't have any, some had had that. And so again, there's an inequity already persistent or existing based on the infrastructure, the structural factors that we have within clinics. And maybe it's equality, is not equity, maybe, but there wasn't a commonality across each practice. And so the second part of your all model, which I know you know very well, Chelsea, is the virtual patient navigators, and making them available to patients. And so there is some follow-up, and there's a human behind that text. So how do we scale this up in a limited resourced health system that's very mission oriented, that is the largest safety net health system in central Massachusetts? How do we scale this up? And I thought that second component was really important to do good for our patients and families. So resource sheets are one thing, but having some type of human connection even through texting, which, in this day and age with the Gen Z, it's like, it is kind of it is kind of like human connection. It is really important. And so that was a really, really appealing to us as well, given the resources that we had across the system. So we rolled it out in April, and I can show you some data in a minute or two. I think all of us are blown away by the screening rate. They're much higher than our passion projects, which probably makes sense because we had leadership buy-in. We had buy-in from the clinics. We did a lot of training and did a rollout. We offered it through MyChart, which so far has been the biggest completion. Oh, thanks, Stacy. Looking at this, so this is kind of like a busy slide. But you look in the left-hand corner. We've completed over 47,000 screenings, and this started, I think, mid-April or so. So it's been about, I guess it's been about 2 months now.
Months, yeah.
And over almost 67% of patients who are eligible have completed a screener, which is pretty amazing.
Yeah.
When we look at the data so far, the majority have been completed by MyChart, so that's on the left-hand side. We offer in-person screening as well, and so that's by paper pencil, pretty much in our clinics. I hope one day we can move on to kiosks and iPads, but we just haven't had that opportunity yet, financially and logistically. But hopefully we'll move in that direction in the future. And then GetWell offers texting as well, and that's been about 3,000, and we expect that to expand over the next few months as we. Right now, they can only get texted once they're in the waiting room. But we're hoping to send that text 2 days prior. And so what we do, and we have a great data team, is that we can look at this data all different ways. We can look at it by screen by practices. We can identify the practices that are doing the best, the practices that need some additional assistance, and we can share this data, kind of peer pressure, to show where people are. And then that's something we're going to plan to do in the future as part of our implementation strategies. We've done this in other projects, and that's been pretty successful. Yeah. So again, this is not something I would have thought of doing until COVID and the social unrest kind of made us think about like looking at a health equity dashboard. And so, UMass Memorial Health, for many of our healthcare ambulatory outcomes, we've been looking at it by race, ethnicity, language, insurance status. And this shows you on the left-hand side that you look at the percentages, that the majority of screenings been done for our white patients. So about 69% of those who were offered screening completed screening, but almost over 50,000 of our patients who were screened were white. But for our Latino population, it's about 59%, and our Black population a little bit less, Asian kind of similar as well. So you can see that there's racial differences. And what you can see here kind of gets a little messy, but what you can see here, if you look at positivity rates, so on the lower right-hand side, so these are social risks and social needs, so two different things. And you see there's not a direct correlation, but if you look at it, so on one hand, our population who is white is getting screened the most, 69% versus 60% for our BIPOC population. When you look at risks, our white population is about 10%. Our Latino population has twice, and our Black population has twice the risk. And you look at needs, it's 60% for whites, and for Latino and Black patients, it's 22 to 26%. So you can say it's about 4 times. So what's happening is that our BIPOC population has 4 times the need, but they're being screened 10% less than our white population. And so you can see, like, we haven't solved this yet. If we continue to persist on this, you could say we're potentially worsening health inequities, and I think that's absolutely true. So what's important for us is look at this data, share it with our clinic leaders and our leadership, think about how do we address this. It makes sense on one hand why this is happening. So when you take a step back, MyChart is our biggest source of completion rates for our screeners. It's only in English. So we don't have it in Spanish yet. We don't have it, although we're working really tirelessly, and Dr. Alper has been leading this charge. We hope to get that in the near future. but we don't have it in all languages. So Spanish for our next one, hopefully we'll get in other languages. With Get Well Texting, we have it in Spanish, Portuguese, and English, but that's been our lowest screening modality. So hopefully we can buff that up even further. We do have in-person screening, and that's available in all languages as well. So, so it's just really important for every health system as you move along, think about looking at the data, stratifying it by race, ethnicity, and we're planning to stratify this by language as well, which we haven't built yet. We're kind of like building flying the airplane at the same time right now.
Normal.
You can tell. Looking at it by insurance status as well.
Yeah.
Doing geocoding as well to look at by geographic area in the Worcester area for our medical center to see where those needs are, which probably is not surprising. It probably overlaps really well with maps of redlining from Worcester, which we have, as well as segregation. So I can't remember what the question was, but basically,
basically answered it.
Yeah, basically we started this and we recognize we have to be humble in this work, and we recognize that we're doing a lot of good here, but there's a lot of unintended consequences, which we kind of forecast, to be honest. Health systems have to be aware of this as they move forward.
Yeah, and I do think one of the good things that you see by doing it this way versus kind of making sure you're not doing that double harm is that we are at least navigating everyone, right? So regardless of who's being screened, how they're being screened, everyone's getting resources, which I think is one step in the right direction to ensure that, even though Black and brown individuals are being maybe screened a little bit less, for those that 22%, 26% who are expressing those needs, they're getting something in their telephone back to them to say, all right, we heard you, and here are a few resources to help you out. So it's one step, but I 100% agree that there's more work to be done. But I do believe that this is a good step by putting forth the effort to screen everyone, ensuring you're looking at the data, making sure you're trying to get resources to as many folks as possible. And just, I adore the fact that you all are introspective. I adore the fact that you all are truly into this. Yes, there are financial gains to be made, but more so it's centered on making sure you are doing no harm and really expanding the thought of health equity. So you all will always be champions of health equity in my mind. I am honored to share this little time with you and others on the team, Dr. Alper and Stephanie. I hope she's listening in while she's at home or not, and Allison and other folks who are out there who have just been absolute joys to work with. And so we appreciate your time and for talking with us today. Yeah. And I believe there's some questions that are out there.
Sorry, can't say one. Sorry, I can't stop talking. I get excited about this work. But it's definitely a team. I have to be respectful. I'm the least important part of this team. We've had an incredible team from Get Well and from UMass, and Stephanie Duan-Soares, who's been really leading the work. And she's on maternity leave right now. But Stacey, thanks for the slide. So I agree completely. Compared to our passion projects, we're doing so much more screening. I think all of us were really surprised in the first 3-4 days. It was it almost, I think, superseded the screening we've been doing for years. And so just by increasing that number, we are helping more patients, absolutely. And you can see here that Get Well's delivered over 7,000 resources to screen patients who've requested help. So using Find Help, the platform, which we had already built in and worked with at UMass, leveraging that platform to be able to instantaneously send out the resource sheets, resource information by text in English, Portuguese, Spanish, and then also be able to have a virtual patient navigator involved as well. Has been great. I think a lot of promising results that will only get better and better with time. I have no doubt. I think one thing that we've been trying to do is continue to increase patients' awareness that this is happening. This type of screening is just very different from what many patients conceptualize as what what medical care is.
Yeah.
Getting text, getting a virtual patient navigator via text, I think there has been some hesitancy from patients to understand, is this real? Is this spam? Is this what's going on here? And, but I think that's part of the growing pains. That's part of the culturation. And we're continuing to market it on our screeners and through MyChart messaging and other ways. And that's just going to take time and growth for this to become part of the healthcare system and part of routine care. Like we check blood pressures at every visit. And I think it's going to take some more time to make that part of the norm. So I think that's to be expected and to be anticipated as we move forward.
Yeah, makes total sense. Makes total sense.
Well, thank you both. We do have a lot of questions actually in the chat. So I'm going to stop sharing and I'm going to read out some of these, and either Chelsea or Arvin, you both can grab them as they come. The first question we have is, has your team, and this would be for you, Arvin, has your team developed a formula to determine financial ROI that early social determinant work can have on patient health outcomes? So essentially, how do you measure ROI for investing in doing this work?
Yeah, that's above my pay grade, but yes, that's something that we had to talk to our chief financial officer about this, because this was an investment and a risk that we took to partner with Get Well. And I know, Chelsea, your team or the finance team, went through some ROI modeling for us. I think the ROI it's how you it's kind of like fuzzy math to me, to be honest, because there's a lot of expectations, a lot of things that you can try to model for. The impetus. Now I'll give it to Chelsea in a second. The theory, the holy grail, is that if you move upstream, address these social factors which we know impact health negatively, it'll improve health outcomes and health utilization outcomes. And I think that's something, particularly for patients with chronic diseases and multi-level illnesses. So I think conceptually it's there, and I know Get Well, you guys have done ROIs and as well, and that's something that we're going to look at as we move forward, looking at health utilization and things like that. But but it's hard to always prove, I think.
Yeah, I mean, I think, at base, the Medicare payment system has it. I think it's built in where you're reimbursed like $18 for a outpatient screener and something like $7 for an inpatient screener. And so our overall system probably costs less than $2 per patient to screen. So if you're looking at that, you're looking at, probably a 3 to 4 times ROI just from what Medicare will reimburse for completing screeners. It's different in other states, right? There's some states where it's as high as $35-$40 for every screener you do for Medicaid patients. And then kind of what the penalty looks like from the IPS perspective. So it can layer in there the kind of the different financial levers that are there. But I think ultimately we look conservatively, we believe it's probably about a 5 to 7% percent ROI gain that's there for completing it, as well as doing the resource navigation.
Great. Another question. We actually have a few questions here related to MyChart. So Arvin, I'll ask you to tackle this one. So one question is, where in your MyChart workflows is the SDOH screening taking place? Is it part of the e-check-in process, or is it post-care like the Get Well process?
Oh, good question. It's part of the check-in process. And so it opens up, I believe, like a week before, typically for patients in general. And so there's a bunch of screeners that they would fill out, and we've added the SDOH screening as part of it.
And another question related to MyChart is, I think this is related, do they fill out the SDOH questions prior to admission in a hospital setting or only after admission?
That's a good question. Good question. We're planning to roll out our inpatient side of SDOH screening this week, but because of some unforeseen circumstances, actually not related to SDOH screening, but some of the other health equity screening that we're trying to package together, we needed to pause it. So we've been thinking about this a lot. And we are offering it through MyChart before hospital admissions, also through a text system, through Get Well. And if that doesn't happen, then we are having our nurses ask the questions for our social risk questions. So it's about 7 questions to capture that data, which is really part of the regulations. And then if there's any like dire homelessness or food insecurity, to then get referred to a social worker or case manager, depending on which hospital, which resource availability there is for staffing. Upon discharge, if they haven't completed the social needs part, saying, do you want help? Or even the social risk questions, GetWell will text that out upon discharge. Maybe they were too sick in the hospital to get this filled out. And then they're offered resource sheets and a virtual patient navigator upon discharge. So it's kind of a 2-tiered system, but we thought some of the connectivity part to resources, and Stephanie really helped me think this through along with GetWell, it may work a little bit better upon once they get settled at home upon discharge, and a different frame of mind to kind of engage with a virtual patient navigator to actually be able to access those resources. So it's kind of a two-tiered system, not two-tiered, but a 2-level system: pre-admission and then post-discharge as well.
Yeah.
Great. And I think one other just related question to that you had in your data, have you noticed differences in completion rates between MyChart, where it's done before the appointment, versus GetWell, where it's done post-discharge? I do think you had some data on this.
Yeah, so the data I showed was on the outpatient side, which is still all pre-visit, pre or during visit. So the GetWell is in the waiting room. So I don't know what you call that, pre-visit or during visit or something like that. So far, the GetWell texting has had the lowest frequency, but we're planning to move it a little bit earlier. We're planning to make it more part of the clinic norm for the front desk staff to offer the texting instead of the resource, instead of the paper pencil screener at that moment. So
lowest frequency, but not the completion rates are still fairly high. I pulled up the data slide.
oh, thank you.
It was in the I have it open on my other screen. I don't know if Stacy has the ability to pull it up, but it looks like completion rates are so MyChart. Oh, maybe I should make this larger so I can tell you for sure. MyChart has a 94% completion rate. Inpatient has a 91. In-person 91. GetWell is 100% completion rate. So it's a slight difference in completion rates depending on how the screener happens.
Yes, and just can remind me, like the texting, I think it's almost like it's hard to complete it it's hard to submit unless you've complete those questions. There's also, I do not want to answer it, response. So we offer that for every response. But I think with the texting, it kind of forces you to put a response in. And so I think that leads to the 100% response rate. So yeah, thank you. I kind of mismanaged that question there. But the completion rates are higher for GetWell texting.
I think we have time for maybe 2 more questions. One is, how are you handling the challenge of low-income patients who may not have phones or may not be responsive to texting? These are patients with the greatest needs, but oftentimes most challenging to reach out to after they leave the hospital or clinic.
Yeah, that's a great question. Chelsea, you want to?
Yeah, so there's we have a flow in place to reach out to folks who need telephonic outreach. It's allows us to leverage our community navigators to make that outreach. We collaborate closely with our friends at UMass to leverage their language line if we're using some of the other languages that might not be in play. That is one of the higher reasons we see why we're actually having to facilitate a phone call is because of a language need. So I think that being able to identify those patients who need telephonic outreach and complete those calls while still being able to complete the screener with them on their behalf and then make sure that the data is still flowing through is the process that's kind of in place. And then there are patients who can be text messaged and their response is, could you call me? And so we have lots of those patients that exist as well, where our navigators are able to hop on the phone. They can see that they need that call. They can hop on the phone and talk to those patients and complete that screener or help them with additional resources. And so I think having that additional support to do that telephonic outreach is what I think allows us to help the team scale kind of what they're hoping to accomplish.
For sure. And I think studies have shown that probably about 95% of low-income patients have a smartphone. So I think it is a barrier for a small subset, but it's probably smaller than we think of when we think about texting. It's become part of like our culture for all socioeconomic groups by and large. And then like Chelsea said, we offer by telephone, and then in person, we offer screening in multiple languages, all languages, the top 10 languages for our patients. And we have interpreter services on site as well.
I have just a few more questions related to codes. So does your team use ICD-10 codes within the patient chart, as well as post-screening, are you using billing for the new HCPCS codes related to those activities?
Yes, that is the goal. I believe the Z scoring, and I think for Mass Health, for our Medicaid program, a segment is not Z codes, it's something else. We're trying to like wrap our heads around it, but the social risk scoring should tie directly to Z codes, and we're trying to automate this for our providers, so it'll be part of the billing process. And that's our next phase of just making sure we can get that documented properly. But we are collecting that information. But I always get confused with Z code or some other modality for Mass Health we're using.
And lastly, what has this meant for your clinicians? Has this helped them save time, seeing these completion rates? What has it meant for them? We've talked about what it meant for the patients, but what have you seen the impact on your clinicians?
Yeah, it's a great question. It's I think it's a little bit TBD, to be honest. I'm just gonna be perfectly honest. Like the good part is that we're getting much higher screen rates than before. But theoretically, the provider doesn't have to be involved at all, right? Because the text goes out to patients, they get the resource sheets, they get connected to a virtual patient navigator, not to a social worker or a navigator within the clinic. It does get captured. It does get captured in Epic, and so it is in their EHR and pretty instantaneously. So you can see the SDOH part of the chart and look at the needs and the risks and see what's happening. I think that it's hard to add one more thing to a busy workflow for clinicians who are kind of have their shtick that they've been doing for many years, and adding a different component that's non-medical. And so I think as we continue to evolve this, I think that's something I want to try to emphasize even further, that just saying something like to our patients, thank you so much for sharing your needs. This is really important for your health and for your family's health. We're here to support you. I'm so excited that you got the resources and the virtual patient navigator. Anything we can do, just reach out to us. 20 seconds, but acknowledges their needs, acknowledges that they're getting some assistance and that you're there to support them. And I think that's something we hope to build in as we continue to iterate this model going forward.
Well, thank you both. That's a great place to wrap. Arvin, Chelsea, thank you for taking the time to talk about this important topic with us. For those, we didn't get to all of the questions, but what we do have here is we have a QR code that you can scan. I'll leave this up for a few minutes. So, you heard from our experts today, but if you have other questions or if you'd like to schedule a demo of our SDOH screening and navigation tool that was used and discussed today, you can go ahead and scan here. That'll just take you to a form. And then once you exit out of today's webinar, there'll be a short survey that'll pop up. We appreciate if you'd let us know if you found this valuable. And thank you again for all of your attention and your engagement. And to our speakers, thanks for doing this great work for these communities that are so important to make sure they don't fall through the gaps. So thank you again for everything you're doing.
Thanks so much for your time.
Thank you.
Thanks, Chelsea. Thanks, Stacey. Thanks, everyone.